Preoperative clearance is more than just getting a green light from medicine. It's a critical surgical responsibility. In this video, we break down what every surgeon must understand about pre-op evaluation: cardiac risk, pulmonary optimization, medication management, and when to delay or cancel surgery. Pre-op clearance is often misunderstood. It's not just a checkbox for medicine. As a surgeon, you are ultimately responsible for ensuring that the patient is medically ready for the stress of surgery. You must know who needs further testing, what risks are modifiable, and when to postpone or proceed. In this video, we'll break it down using real cases and evidence-based tools. The three core questions in pre-op include the following. Can this patient physiologically tolerate surgery? Can we reduce the risk further? Are there any red flags that require delay or specialist input? If you can answer those confidently, you've done real pre-op clearance. Cardiac events are the number one cause of perioperative mortality. Use a stepwise approach. In emergent, is the case emergent or elective surgery? If emergent, stabilize the patient post-op. If elective, proceed to risk stratification. What are active cardiac conditions? Unstable angina, recent myocardial infarction or heart attack less than 30 days, severe aortic stenosis, decompensated heart failure. These are the red flags that delay surgery. The next one is assess their functional status. We utilize METs or metabolic equivalents. If it's greater than 4 METs, then it's good. If it's less than 4 or unknown, use the RCRI or consider a stress test. RCRI is a revised cardiac risk index. This includes CHF or congestive heart failure, coronary artery disease, chronic kidney disease with a creatinine greater than 2, diabetes mellitus on insulin, high-risk surgery, cerebrovascular accident or a stroke. If it's 0, then it's low risk. If it's 1 or greater, consider optimization. For very high-risk patients, you have to consider consulting cardiology to delay elective surgery if needed. Now let's go to the lungs, using pulmonary risk and optimization. Pulmonary complications include pneumonia, atelectasis, ARDS, and prolonged vent dependence. What do we evaluate? Well, we look at their smoking status, their baseline oxygen needs, do they have a history of COPD or an asthma history, a recent upper respiratory infection or pulmonary infection, and their functional status and exercise tolerance. What interventions can we perform? Well, number 1, encourage smoking cessation for at least 4 to 8 weeks preoperatively. Number 2, using incentive spirometry and a pulmonary toilet. Avoid unnecessary pulmonary function tests unless lung resection or significant disease is considered. The fourth one is prehab for frail or elderly patients. For labs, imaging, and functional status, labs should be ordered based on comorbidities and surgery type, not automatically. If you're using a CBC, you're looking if the patient has anemia or thrombocytopenia. BMP looks at electrolytes and your kidney function using creatinine. For coags, if on anticoagulation or if there's consideration of liver disease. Liver function test is only if known liver disease is present. Chest x-ray, not routine, only if symptomatic. EKG for males greater than 45, females greater than 55, or cardiac risk factors. Stress testing, only if it will change management. Functional assessment is critical. Frailty scores, gait speed, and metabolic equivalents are more predictive than labs. Medications, to stop or to continue. Medication management is where many pre-op fails. We continue beta blockers if already on them, statins, antiepileptics, and antidepressants, except MAOIs. What do we hold? We hold the following, which include ACE inhibitors or ARBs, which are held the morning of surgery, diuretics, unless the patient has CHF, insulin, which reduces or is held to short acting, oral hypoglycemics, you hold the day of, and anticoagulants, they are bridged as needed or held, and you can consult cards or heme. You can also check out one of my posts which actually discusses anticoagulation. When do you actually hold it, how many days before, and when to consider restarting it. Don't forget, supplemental herbals hold for 5 to 7 days pre-op. When to delay or cancel surgery? Well, number one, active infection. If they have a urinary tract infection, cellulitis, pneumonia, which is critical or does affect the surgery, then it's something that you may consider. Hemoglobin less than 7 to 8, unless emergent, or if it is the cause, let's say you're resecting a bleeding cancer. Decompensated CHF, COPD, electrolyte derangements, recent stroke or transient ischemic attack, an INR greater than 1.5 on warfarin without a plan. Bottom line, optimize what you can, delay only when the benefit outweighs the harm. So, clinical pearls. Summary. Surgeons must understand clearance basics. Focus on cardiac, pulmonary, and functional status. Don't overtest. Target your evaluation. Pre-op is about risk reduction, not perfection. Communication early and clearly with anesthesia and medicine is of paramount importance. If you guys like the video, please click the like and subscribe button and check out our other videos. And I'll see you guys next time.